Good day, everyone. We've got about 30 seconds before we're going to start the webinar right at the top of the hour. So please stand by. All right. Let's get this show on the road to be responsive to everybody's schedules. Thank you all for attending this AIM High webinar, putting the I, International, in AIM High, a comparative analysis of emergency medical services delivery in the US, Canada, and the UK. We have an esteemed panel from around the world that are going to be sharing their insights in how their systems work and some of the challenges that they face in their systems. And you may be surprised by the similarities in some of the challenges and in some respects, some of the delivery. Just want to let you know that this webinar is being recorded, and we will make a copy of the presentation recording available to all registrants, including attendees, by tomorrow morning. So you'll get a link with instructions on how to access and even download, if you'd like, the recording of the webinar. There's a Q&A box in Zoom. Those of you that are familiar with Zoom webinars, you'll notice a Q&A box. The chat for participants has been disabled for this, but if you have questions or would like to have any additional information, and some of the panelists might put information into the Q&A section, please use the Q&A function, and we will address some of the questions at the end of the panel. Rob, I want to introduce you as the president of the International Academy of International Mobile Healthcare Integration to talk about the organization.
Thank you, Matt, and good morning. And I've had a quick look at those that have registered, and I'd like to welcome folk all the way from the east coast of Australia right through to the west coast of the UK and Wales. Your presenters are currently spanning 8 hours of international time zones, and our participants spanning much, much more than that. So I'm absolutely delighted to welcome everybody to both this live recording and also to, if you catch us on demand. So we are currently at 9 o'clock in the morning and 5 o'clock in the afternoon simultaneously, which is always exciting. I'd just like to introduce everybody to the Academy of International Mobile Healthcare Integration. We are a predominantly US and Canadian organization of high-performing, high-value EMS systems that pride themselves on delivering world-class EMS. We are sole providers. We publicly report our information and our data, and that's where we come from, because we're very happy to share, we're very happy to benchmark, and of course we publish a number of reports and of course webinars where we seek to deliver and share best practice, but also to learn best practice from other colleagues as well. And so that really brings us on, Matt, to today and why we're here today. Those are our member organizations. And another point of that, I can see also from the registration, there are folk out there that both nationally and internationally. We would love to have you come and join us, come and be a part of AIM High, be a part of sharing your own best practice for the good and benefit of the rest of the EMS world. And so hit myself or Matt up, and we'd be delighted to welcome you along. Also, AIM High over the years has had an Excellence in EMS Integration series of awards. The nominations are open right now. You can see the QR code in front of you. Again, click that, download that. Again, we want to recognize and to highlight and to celebrate all that is good and best and excellent in mobile healthcare delivery. And so please enter, as Richard Branson once said, and the British National Lottery once said, you've got to be in it to win it, Matt. So have a look at that. And so let's bring in our international guests. And first of all, poor Adam Hines is under the weather today. And so in order to make sure we have somebody with an original English accent presenting for the Team United States, Matt's gonna pinch hit for that. But also international colleagues, international guests. Firstly, a former Prime Minister, President of AIM High himself, now from British Columbia. Kevin, please introduce yourself.
Yeah, thank you, and welcome everybody. Good morning, good afternoon, good evening, wherever you're joining from, and thank you, President Lawrence, Prime Minister Lawrence, however they refer to you, and certainly thank you to Matt and AIM High for pulling this together today. It should be a great discussion. My name is Kevin Smith, and I am the Chief Transformation and Strategy Officer with British Columbia Emergency Health Services in Canada. Back to you, Rob.
That's great. And just to point out that when Kevin was the chief of Niagara, of course, Niagara were a AIM High member, and Kevin was our first Canadian president, although as we, with a smile, say Prime Minister. And so you can work out whether I'm Prime Minister or President to pick.
And Mr. President, I believe that Mr. Past President may have left something off of his verbal resume.
I did. Something very important that reflects obviously my background is I am the president of the Paramedic Chiefs of Canada, which promotes leadership and advancement of paramedic services across Canada. How could I forget that? But thanks, Matt.
How could you forget that, Kevin? And of course, there is a bit of a theme emerging here because we invited Kevin for many of those reasons, obviously from his lead of paramedic chiefs, but also lead from the UK Association of Ambulance Chief Executives, amongst other things. Jason Killens over there across the pond. Jason, good evening and welcome.
Good evening. It's good evening for me, but good morning and good afternoon to everyone that's joining us. Great to be with you, Rob, Kevin, and Matt. As you said, I'm Jason Killens. I'm the Chief Executive of the Welsh Ambulance Service University NHS Trust. So that's the National Ambulance Service for Wales, one of the 4 nations in the UK. But as you've said, Rob, I'm also the chair of the Association of Ambulance Chief Executives, which is a membership body which represents the 14 NHS ambulance services, National Health Service ambulance services in the UK.
Great, and welcome to everybody. And so what we have lined up for our listeners today is an assessment of EMS systems in each country. And what we've done is we've identified a sort of number of questions or points or items that we'd like everybody to highlight on. And we're going to give each speaker a 10-minute slot really to present their national system, to highlight their, as you can see on the screen there, some of the things that we want to talk about. Once we've gone through that, then we'll come back and have a Q&A. We'll do some comparative analysis. We'll do some Q&A. We'll ask the tough questions, and we'll see where we go from there. So without further ado, we're going to turn it over to Kevin and Canada. Take it away.
Well, thanks, Rob. And again, thank you for having me on, joining this great conversation. 10 minutes to talk about a system, and I'm going to be talking about systems across Canada, not just my experience currently in British Columbia and my past experience in Ontario with Niagara EMS, and trying to share some of the key points that are of interest to an international audience about, maybe what sets apart our system from others, the good, the bad, the ugly. And so within this time frame, I'll go through a few of the key components, and hopefully in the Q&A time, we'll have time to dig into anything that's of primary interest to people. So really the first part about funding and level of involvement of government oversight. I mean, this is paramount. This is foundational to the survival of any paramedic system, ambulance operations, large and small, is really about how is it funded and how is the governance administered. In Canada, We have 10 provinces and 3 northern territories. So across the landmass of Canada, it's split into these provinces and territories. And within each of the province and territories, it's really their responsibility for the delivery of healthcare. So at the federal level, at the national level, it's not really a responsibility of setting up paramedic services at all, but really up to each individual province. And so each province and territory actually administers it a little bit differently across the province. So for example, in British Columbia, where I currently am located, we're a provincial government entity, and we are the sole provider of 911 emergency services for both land and air, and as well as interfacility transfers. Critical care, infant transport, all of the components that you would think of that make up a robust and modern paramedic service. Our service, we cover 5.7 million people across the province, and that's over 944,000 square kilometers, or for our American friends, 364,000 square miles. So it's a huge landmass bordering upon Alaska and 3 other states to the south. And we also operate 3 of our 911 dispatch centers, communication centers, as secondary PSAPs. So when you look at that, how it's administered, it's funded through a tax base that is primarily through provincial tax dollars that go towards the healthcare system, and then in part how much is allocated to the delivery of emergency health services. Take in contrast to a province like Ontario, which is the largest of our provinces in population, there's 55 different ambulance services that operate within that province, and they're operated at the municipal or at the regional level, whatever the most upper tier regional government is that provides governance and administration. And so when you have that many, 55 different services, of course, there's slight modifications in how each of those services are delivered, but primarily the regulations are set at a provincial level, so you have to follow provincial standards. Licensing is at a provincial level. We'll talk about that in just a few moments, but it can be created, as I mentioned, in a different way, depending on what province that you're in. But the baseline across Canada as a publicly funded healthcare system is that we generally don't have large user fees. So if you're a resident of the province in which you require ambulance services, it's usually covered through your provincial healthcare system, or there might be slight user fees. So in Ontario, for example, a user fee of $45, which is pretty modest. And then, it can be up as high as $245 in Saskatchewan. But in comparative, those are relatively minor, and usually your private healthcare covers much of that. So we don't really rely on our funding coming through revenue generated through costs and how we provide interventions to patients. It's funded in advance through these budgets that are set at that local or provincial level. So we don't do a lot of billing in our services. We do make sure that any of that revenue that can be collected as part of our systems, regardless of where we are across the province, we do. But most of that goes back into the healthcare system and not directly back into ambulance services, although that again differs in some provinces. So when we think about the way that we recruit and retain, like other health-related professions, there's been an increase in paramedics that have come through this as a profession and gone on to other professions. And we're seeing that particularly, in the last 4 years, like all other type of health professions since the pandemic, that people are feeling exhausted and looking for an alternative profession to get involved with. But having said this, our colleges and other training institutions continue to fill seats. So there is a desire of people who want to get into this profession. And so a lot of that is really making sure that we are providing clear information up front as to what the role of a paramedic is in Canada these days, because much of what you see in Hollywood and through other media isn't reflective, as we know, of what paramedics' day looks like. And so this is where we're seeing, maybe some attrition through people coming in and being disillusioned at what the career is. So trying to make sure that we're working with our training institutions and our professional bodies to make sure that we highlight and promote, the great work that paramedics and other professionals within our system do to make sure that we can attract and retain the right people. And we're seeing that, the expanse of the profession, particularly in the areas of no acuity or low acuity. And no acuity, I mean that they're not being triaged within our system. We're going out providing preventative care in community paramedic type models, or low acuity type settings where we're using mobile integrated health teams to go out. And so it's really diversified what we think of as a paramedic service and the type of professionals that are within it. And that's a great thing as we provide opportunities for people to continue to grow and expand. But at the same time, it's putting pressures on the profession, because we're trying, to fill so many holes, and we're being called upon as professionals to fill gaps and trying to be all things to all people and all healthcare problems. And so it's a real challenge for us, especially when we think about ED closures in some of our rural areas, and paramedics now working in emergency departments to help fill that community need. So that's meant there's been a large movement of young people coming into the profession, and we want to make sure we protect them and provide them the resources and supports that will help to make them successful. For regulation, we really think about that self-regulated component, and across Canada it again varies. There are 6 out of our 10 provinces that are self-regulated, with the exception of British Columbia, where I am, Ontario, the largest populated province in Canada, as well as Quebec and Newfoundland. And these are government regulated, and so you are working under a license per se, but of something that's issued by your provincial government. And it's been coined here in Ontario, when I was here, as the most regulated, unregulated profession that we have, because it is so stringent and tight with these regulations, but it's not by a college of peers. And certainly the effort of the remaining provinces is to work towards self-regulation as a profession here across Canada. See, I have about 90 seconds left. I'll try and get to some of the key points as far as innovation, mobile healthcare, and things that are moving this country forward in paramedic services. Consensus among paramedic service leaders in Canada is that we must move away from response times as being that key performance metric that we've used for decades, and that's the only metric that's publicly reported. What we're seeing is this big shift in both conversation and in actions to use measurable clinical outcomes and relate that to paramedic interventions and adjusting our response plans that are using evidence-informed decision-making rather than use arbitrary response times. So it's a conversation I know that is huge, in our space globally about how we're doing these things. And it's really now about educating our elected officials and the public on changing expectations when they call 911 on what type of healthcare they are to receive. And when we think about the original triple aim in Jack Stout, thinking about making sure that we have high quality care, cost efficiency, and reliability, we're now embracing the quintuple aim and making sure that we are including accessibility, equity, and certainly making sure the health of our workforce is paramount. Rob, before I go into something else, I'm going to pause there because I'm probably at the top of my 10 minutes, and I'll turn it over to our next guest.
That's great. So already, for those that are not listening from Canada, there are some themes that have started already to emerge that we have in common. So, Kevin, for the moment, thank you. Matt, who's on next? It would be Matt, and the guy with the original Virginia accent, that would be me. So, Matt, do you want to lead off?
Sure, I'll start off. Well, obviously, EMS and ambulance service delivery in America is a bit different than we've heard Kevin talk about in Canada. First of all, with regard to funding, which drives most of it, as opposed to perhaps Canada and what you'll hear from Jason, our system is primarily fee-for-service revenue generated, as is the entire healthcare system. So that changes delivery exceptionally. In many cases, the healthcare system in the US and EMS is primarily wanting to do more responses, wanting to do more transports, because we're paid, reimbursed on a per transport basis, much like your physician wants to have more office visits, wants to have more procedures. So that drives a lot of the reason why we have the response plans that we currently have. Because again, it's fee for service driven primarily. Now, some governments provide funding when the fees don't match the service level that they want, et cetera. But predominantly, the economic model for EMS in the US is fee for service driven, which in some respects limits innovation. As you'll hear probably later in the QA, our approach is we send an ambulance to every call because we want to, because that's how we get paid. And we want to transport everybody to the ED because that's how we get paid. And that's really sort of the fundamental structure there. In terms of oversight, we've got local, and Kevin talked about that in Canada, we've got local oversight to some degree, varying from very highly regulated locally to not necessarily being very highly regulated on a local level. But states primarily are the regulators for EMS. But even in that patchwork, it's a little bit different. You have some states that have very highly regulated, highly involved state EMS offices like California. Then you have states that have kind of a hands-off approach, let the local leadership, medical directors, agency chiefs, decide levels of service, certifications to a large extent, or credentialing, I should say, not certifications, scope of practice, like in Texas. Texas, very little regulation. Whatever the local medical director sets as the level of care provided, as long as they provide the training and credentialing, that's how it goes. When the state EMS office comes to inspect ambulances in Texas, they have the list from the local medical director that says, here's what we're going to check your ambulances for. There's no state required list of anything. So it really runs the gamut. And that decentralization can be both great and not so great, depending on the state that you're in. In terms of retention and recruiting, obviously a huge issue in the US. Paramedics specifically are a hot commodity. They work a lot in healthcare professions outside of EMS, even though they may be certified. But to the extent that we are even able to quantify how many paramedics we have, how many EMTs we have, how many advanced EMTs we have, it's difficult to pin down that number because each state perhaps regulates and supervises, and in some cases even certifies people differently. But retention is a key issue. However, referring back to the first comment about the funding model, because reimbursements are generally low and most EMS systems are underfunded, they are not able to pay a wage that most EMTs and most paramedics would be willing to accept. So that makes retention very difficult, makes recruitment very difficult. The pandemic obviously did not help that at all, but it is a primary focus for many EMS systems and agencies across the country, regardless of your agency type. There was just a news story that was shared on emsintel.org. See that, Rob? We just put that plug in for you.
Thank you for the shameless plug, Matt. Good job.
About an EMS system, a fire-based EMS system in Southern Texas, who had a 30-minute response time to a fatal pedestrian crash. And the union president said, hey, we're short-staffed. We're down 30 firefighters. We can't put the ambulances on the street that we want. So irrespective of the type of service that you have, recruitment and retention, primary issue. Education and clinical certification.
Actually, Matt, before you go there, can I just jump in with one thing that's probably relevant to our international colleagues and those listening? That, of course, we've heard from Kevin. We're about to hear from Jason. We have neighbours with regional or provincial EMS organisations. And so they are probably smaller in number, but larger in magnitude and geography. And I'm sure you've already got that sense from Kevin, and I'm sure we'll get that sense from Jason. But for international colleagues listening, we have a system called NEMSIS, the National EMS Information System. And also, Matt, I'm contractually obliged to say this. Once you've seen one EMS system in the US, everybody join in. You've seen one
Never
EMS
seen one
system in the
EMS system in
US.
the US.
And the reason is because according to NEMSIS data, and of course we can discuss that, the paucity of the data, the number of agencies that report into our national EMS information system is 14,369, and that's those that are actually signed up to do it, which means that we saw over the space of a year 54,190,000 EMS activations, and off the back of that 36,367 those that were, quote, treated and transported. And if you do the math in the difference, of course, where Matt's about to go or has already said, is most of that number in the middle is stuff we're not paid for. So to put it into scale and perspective, we have a lot of smaller organizations, of course, that are trying to fight their own way forward and develop their own funding models and indeed, dare I just say, survive, Matt.
Great point, Rob. And as everybody knows, Rob's favorite four-letter word is data. So
It is.
thank you for sharing that information, and thank you to NEMSIS for being able to make that information available for the profession and for those who are interested in it. In terms of education and clinical certification, states often regulate what those requirements are for certification. We do have a private company called the National Registry of Emergency Medical Technicians that many of the states use as the test taking process, and then they issue a state certification based on the passage of the National Registry exam. Great organization. They give a huge benefit to the industry and to the profession because of the data that they're able to generate and the research that they do on the workforce, and they're very, very good about doing that. Medical directors play heavy. Almost every ambulance service for sure, and most first response organizations are required to have a physician medical director. Some cases, the medical director is very active and is an EMS physician. In some cases, they might be a PCP, a private practice physician who is donating their time. So it's highly variable across agencies. And I know that the National Association of EMS Physicians is working on some ways to make that a little bit more formal. So they've got some good EMS physician influence into things like education and clinical certification. But it is very much different. And we'll probably hear from Jason, and we heard from Kevin, there's at least some uniformity in some of that. Paramedicine is not universally recognized really as a profession here. We don't have a board of paramedicine that people report to either at a state or national level. It's a vocation, but it's hard to say that it's really a profession, although folks that have been in it for a long time, kudos to you. I've been in it for what, Rob, 46, 47 years now. But that firm recognition of independent practice, if you will, is not there. And we may hear from Jason that might be a little bit different in the UK. The advent of mobile integrated healthcare and community paramedicine has been slow to evolve. It's a great idea. The economic model sucks because we are not reimbursed for not transporting someone to the hospital. But unless you can get the attention of some of the large commercial payers, and now thankfully Congress has a lot of interest in things like reimbursing EMS to not bring people to the hospital. A number of large commercial payers and commercial Medicare Advantage payers are finally waking up to the fact that, hey, maybe we should pay for this community paramedic thing because it saves us a boatload of money downstream by reducing preventable emergency department and acute care utilization. So it's been slow to evolve, but on a kind of a steady pace to really look at how do we prevent EMS calls. Clinical highlights. I think the biggest one right now is blood administration in the field. The paucity of EMS research leads to a lot of the slowness in adopting some new clinical procedures. Whole blood, to some extent, is part of that. We need some good evidence-based, peer-reviewed studies that show the clinical and the economic benefit for whole blood. We've had some conversations I have personally with some payers, and they said, man, this is expensive if you want us to reimburse for it. How do we do that? Is it going to save us money on the back end? And we have to be able to answer that question, again, because of our fee for service type of model, whereas perhaps in Canada, the UK, they've got some additional flexibility to kind of say, hey, yeah, it just makes sense to publicly fund something that's going to save more lives or to reduce average length of stay in the hospital. But that's some of the things that we need to start looking at here. There have been some great other clinical innovations over the last decade. But again, big advocate of we need more EMS research that shows that some of the things that we do matter and that they make good clinical and economic innovations. Very important. Rob, what did I leave out that you think we should be talking about?
So I was talking. Sorry, I was at a session with our colleagues in Nova in Northern Virginia last week, and I did a short talk, and so I'm just going to pick a couple of the sort of headings, if you like, just some of the things that that we're looking at and we're focusing on. And one of the things, and I know you're knee deep in this, Matt. Of course, we're trying to improve safety in our national EMS system. We are looking at the fact that lights and sirens are not necessary for everything. And so a lot of work from our colleagues at NEMSCA, the National EMS Quality Alliance, and others have looked at the totality of calls, and then, of course, the outcomes and the arrival, let's call it data, at hospitals to determine not everything that we see, and we know this for a fact, of course, is life-threatening, and therefore why are we driving at speed and putting the crew and the pedestrian at risk. Matt, you mentioned the news tracker that we monitor at both AIM High and the American Ambulance Association, which is emsintel.org. And if you have a look at that, you can actually categorize, we collect, curate EMS news stories in the US. Sad to say that intersection, street crossing, call it what you will, across the nation's collisions and incidents without involving ambulances are a weekly thing, as are, of course, every 2 weeks in the United States. And I said this to Jason years ago, and he was actually in absolute disbelief. Across the United States, an ambulance is stolen every 2 weeks. That is the average. That's very sad. I'm sorry about that. But so we're looking at that. Obviously, we are looking at getting away, and Kevin's already talked about this, what I always call the Ricky Bobby rule, right? If you're not first, you're last. Response times aren't it all. There is clinical outcomes. The perversity that we sometimes see in the US, where if you have an 8 minutes, 59-second standard and you arrive late and the patient lives, that's a failure. That's perverse. You arrive early and the patient dies, that's a success. That's perverse. And obviously we're working very much towards getting away from that and having clinical outcome data, my favorite four-letter word, Matt, is actually the way forward in everything, both clinical, operational, and indeed political. And I think actually that's our time, sir.
You're right. Let's transition to Jason as we do that. Just to mention that the landmark study done by Jeff Jarvis and Dr. Levy and a bunch of Mike Tegman and others, 86% of the EMS calls in the country got a hot response. 6.9% were a life-threatening call. What the hell are we doing? Anyway, sorry. Do you want to introduce?
That was on national moaning. Over to you, Jason.
Okay, great. Thanks, guys. And again, it's good to be with you all today. So I'm going to give you a whiz through the position in the UK. We'll start with funding and kind of government oversight. So the National Health Service, of which all of the public ambulance services in the UK are part of, the NHS ambulance services, are funded centrally by taxation through government. The money flows through the National Health Service rather than directly to the ambulance services from government, but it is all funded by general taxation, and therefore services are free at the point of delivery. So there's no charge for service provision when a patient, a service user, rings 999, 112 or 911 here in the UK. They'll get a free ambulance or a free contact, at least, not necessarily an ambulance, but a free contact and potentially a free ambulance to scene. From a geography and kind of governance perspective, the United Kingdom is made up of 4 countries. Many of you will know that, but it's England, Wales, Scotland, and Northern Ireland. In England, there are 10 regional ambulance services, and then there's a national ambulance service for Wales, for Scotland, and for Northern Ireland. In those 3 countries, Wales, Scotland, and Northern Ireland, health policy is devolved from the UK central government, and so the local political system, much like a federal and state system, but the local politicians will set health policy for Scotland, Wales, and Northern Ireland. Performance management is delivered. The models vary across the country, across the UK. Again, in Scotland and in Wales, there are systems of health boards who are what we describe as commissioners. So they are purchasers of NHS services, but they are also providers, so delivering NHS services too. And in England, integrated care boards commission the ambulance services. Those 10 ambulance services in England on a regional footprint. In terms of the kind of local position here for me in Wales, Welsh Government are very supportive of our position. I'll come on to in a minute some of the changes we've made, and actually it touches on one of Rob's points just now about success and failure around cardiac arrest and hard time targets. We've just been successful in securing an announcement to remove those here and focus on out of hospital cardiac arrest measures as the primary measure of success for our most serious category of call from later this year. In terms of recruitment and retention, there's no real challenge. There's variation across the 14 services in the UK, but there's no real challenge. Whilst some services will have a problem with the numbers or availability of paramedics on a UK-wide level, there's pretty much imbalance in terms of paramedics coming out of universities. I'll come to that in a second, and vacancies that emerge. And for other roles, EMTs, say, or equivalent in services around the UK, direct entry takes place, and again, generally no real recruitment issues there. There is a retention challenge, or more of a challenge for us in contact centres, so in our control rooms, particularly in call handling, but largely in the frontline operational grades, not too much of an issue. Now, turnover varies, but on average, somewhere around 8 or 10% of the workforce will turn over annually in services across the UK. From kind of an education and clinical certification perspective, I mentioned degree entry paramedics. So all paramedics will undertake a degree at a university. During that 3-year degree, they'll undertake operational placements with an ambulance service local to that university, and other clinical setting placements too. And then they apply for a job, full-time employment with an ambulance service as they come to the end of that degree. There are vocational entry pathways for other clinical grades, for non-registrant grades, so for emergency medical technicians and others. And most services continue to maintain that, and also the ability for continual professional development for those grades to develop, normally in partnership with a higher education provider, so a university, to re-qualify or regrade as paramedics as they go through their career. Paramedics have been registered as healthcare professionals here in the UK for just over 2 decades now. The national registering body is the Healthcare Professions Council. They also look after other allied health care professionals, other allied health professionals, so podiatrists and so on. But they're the registering body for the paramedic profession here in the UK. It's supported by a college of paramedics as the professional body, and they're very active in the development of the profession and its kind of future direction. In terms of other, I guess, points to make about formal recognition, paramedics can go on to advanced practice, generally with a master's degree. We've had consultant paramedics and other senior paramedic clinicians now for many years. Quite a few going on with PhDs and so on in each service across the country. Most ambulance services across the UK now have a director level paramedic on their board. So as part of the governance structure, the peak body within each organisation, most ambulance services have a director of paramedicine responsible for setting clinical practice and driving professional development for that workforce. For my own service here in Wales, we don't have a medical director anymore, and the clinical leadership is provided by 2 clinical directors, our director of paramedicine and our director of nursing and quality. but other ambulance services in the UK do maintain a medical director on their board. Conscious of time, so I've got 2 minutes left. I'm just going to canter through a couple of other bits. In terms of kind of integrated healthcare and community paramedicine, that is prevalent across every ambulance service to a greater or lesser extent in the UK. We've been active in urgent care and seeking to close as many episodes of care in communities safely as we can for many, many years now. Most services will close around 20% of their daily activity using paramedics and nurses in the remote setting, providing advice or directing those contacts to other bits of the health service, so that a response to scene isn't necessary. And there's very much a desire to do more of that. We've got specialist care paramedics now in mental health response vehicles, as I touched on, in urgent care, also with dedicated force schemes, and in palliative care, just as a few examples where we've got specialist programs with paramedics working in different settings, and advanced practitioners in services, often now with prescribing rights as independent paramedic prescribers, will also be rotating through primary or other care settings to develop their own clinical practice, but also support the rest of the NHS. And I'm just about on my 10 minutes, Matt, so I'll stop there. But I mean, I could go on for a long time, but I'll stop there, Rob, and see where the questions take us later.
Great. Well, we are into that kind of discussion phase. And Jason, I'm going to stay with you, if I may, because one of the things you just said there is we don't have a medical director anymore. And we have, Jason and I have actually done a webinar on, or a podcast on that, which we'll put out along with our sort of package later on today. But I got my calculator out. I talked about our NEMSIS numbers before, and I then sort of thought about the fact that you had talked about 10 services in England and one each in Scotland, Wales, Northern Ireland. So for a total of 14 services. I then quickly Googled while I was off camera, 68.35 million people live in the UK, 340 million people live in the US. And so you could be thinking, hang on a second, that's a small amount of ambulance services. But when you divide population by ambulance services down, the US versus UK ambulance services are looking after 48 million people per, one service per 48 million people head of population, right? Whereas in the US, it's one service per 23,000 people. In other words, you are smaller, but you have a large span of control. Therefore, you have a large span of clinical sort of influence. You have a large span of huge recruiting target and huge recruiting task. So how do you exercise that span of control, question one, and then how are you truly doing it? As you said, and I'm sure US colleagues are going, what does he mean, no medical director? So drill down into those sort of span of control as a leader, but also the span of clinical control as a series of clinicians.
Yeah, I mean, look, a couple of things to say. So, I mean, we went through an organisation as a sector about 20 years ago and went from 40-odd ambulance services across the UK down to the 10 in England and the 3 national services in Scotland, Wales and Northern Ireland. So I'll start to answer the question on the premise, Rob, that most of our activity is a single patient contact. Yeah, it's not with other, emergency services, so police and fire. We do that. Of course, we do that every day, and there's hundreds, thousands of cases where we work in partnership with others. But largely, they're single patient care episodes. And to better manage those patients, both in terms of their outcomes, but also from a cost perspective, to make it more efficient and effective. And to provide better care closer to home, we need to work closely with the NHS. The NHS here is structured on a regional basis, and therefore, ambulance services largely mirror, not exactly, but largely mirror those regional footprints. And ambulance services, as big regional providers of healthcare in communities, often see I experience variation in the provision of those health services and see things, see opportunities perhaps to do things differently. So because of the structure of the NHS, and therefore because of the way we are now structured as a sector, very close and integrated with the NHS, we're able to get those economies of scale out and provide better services for patients. Ultimately we've got 10 in England and the devolved nations running trust boards and senior leadership teams. If we had double the number, treble the number, you double and treble the cost. And of course that's capacity, that's resource that isn't available for frontline patient care. On the medical director piece, the board and I here in Wales took an opportunity about 2 years ago. So our medical director here retired then, just about 2 years ago. He'd been instrumental actually in the development of the profession and kind of recognition of the profession here. We promoted our first director of paramedicine to our board, and I took the opportunity, I took the judgment that the organisation was ready, professionally ready, the system was ready for us not to have the clinical leadership of an ambulance service led by a physician, but led by itself, by its own people, by the paramedic profession. And that was because we were 2 decades into registration. We've got multiple consultant paramedics, as I touched on earlier, and so on. So the senior clinical experience leadership is there with its own credibility, with its own governance around it, and its own 2 decades worth of experience to be able to exercise that clinical leadership. In conjunction with other professionals, our director of nursing, for our workforce. We still have access to doctors inside the organisation when we need them, but the primary clinical leadership for us comes from a director of paramedicine, a director of nursing.
Excellent. And everybody, if you have a question, please make sure you put it in the question panel for Kevin, Matt, Jason and myself. Also, another international elephant in the room, let's call it that, is, and there is many names for this: hospital delay, ambulance patient offload time, wall time, ramp time. We can go on and talk about it, but it is an international issue. I firmly believe it's a capacity and flow issue, and I'm going to go to Kevin first, and we'll do a little sort of round the houses on this one, because it is an international issue. What are you seeing now, and what have you seen, and how have you solved hospital handover time, Kevin?
Well, I'll tell you, if I solved it, Rob, I would bucket it and package it and sell it.
We're on the world circuit, mate. Absolutely.
Yeah. It's something that is obviously a concern across every part, really, of Canada, from our metropolitan areas to our more rural areas. And the causes, are everything from overcrowding within the emergency departments to lack of clinical care within the hospital itself for them to be able to stay open, which puts pressure on neighboring facilities. Regardless, we've tried several different strategies across the country over the last, 15 years or more, which includes everything from, fit to sit programs, which Jason, when I visited Wales back in 2018, was a program that we had borrowed and brought back to Niagara EMS, where I was working at the time, where bringing people into the emergency department and not having to be put in a stretcher or occupy a space within the ED itself, but were fit to be able to sit in the waiting room and be triaged as if they had walked in. To ED avoidance, of trying to look at our low acuity strategies, secondary triage being used in several agencies across Canada to divert patients into different healthcare resources that they might need rather than the doors of the ED. And then working with our emergency department partners on just performance improvement, and that's everything from lean processes to ensure maximum efficiency of the resources that we do have. And putting paramedics in the emergency departments in some case to watch patients, or offload delay nurses, as they're referred to in Ontario. Everything's been tried really to mitigate this, and little bits of success here and there, but nothing that really is the lasting key
little bits of success. I'm going to toss it to Matt in a second, but it's been 16 years now since I was a chief operating officer of an ambulance service in the UK, and I was charged with not admission avoidance, but arrival avoidance. In other words, we have to find a disposal for the patient that isn't the hospital, and hopefully that can still be an overarching ambition, aim, pipe dream. Matt, would you like to represent the US in this one?
Yeah, 2 minutes. I will quote my esteemed colleague, Doug Wolfberg, who says that the APOD issues in the US are occurring because we, EMS, are allowing them to occur. In Fort Worth, where I was one of the directors for a long time, decades, even to the pandemic, 22-minute offload times, even at our largest public trauma center that we take 300-400 patients to a day, because the vast majority of patients that we bring in by ambulance to those hospitals go into the waiting room because they are low acuity cases. They do not need a hospital bed. For the patients that do, they're seen right away. If we allow hospitals to continue to hijack our resources, we're going to continue to have this problem. And if you want to find the solution, look in the mirror. Now, in some cases, and Rob, I'm going to pick on California, there was recently some regulations proposed, thankfully withdrawn, that would require the EMS crew to get a signature of a nurse taking over responsibility for that patient. That would have exacerbated this issue. The federal law is when the patient arrives on hospital property, it is the hospital's responsibility. We do not have to stay, and in some cases, we can't administer care. Therefore, we can't monitor a patient in the emergency room. But until we get serious about saying we're not waiting, we're going to put this patient in the waiting room, or what we did in Fort Worth many years ago, we brought in military cots, stacked them up in the ER, put patients on military cots, and left. Ever since then, no problem whatsoever.
Excellent. I want to bring Jason back in, and I chose Jason, got Jason to go last because, of course, one of the things that we've often say, Matt, you've been to many meetings where the phrase "and people will die" is just thrown away. But obviously, with the ambulance hospital patient offload, whatever we want to call it, Jason, obviously you've done some peer reviewed work across both the Association of Ambulance Chief Executives and elsewhere in academia in the UK to talk about the disastrous effect on patients if the ambulances are stuck elsewhere, right?
Yeah, I mean, look, Rob, this you're right. This is an international problem. I experienced this when I worked in Australia before being here in Wales, and this is a perennial problem. It's one which I believe controversially is a choice. This is a leadership choice which systems make to permit or otherwise what we describe as handover delays to occur. But you're right. The Association of Ambulance Chief Executives undertook a study a couple of years ago. In 2021, so 3 or 4 years ago now, which looked at the impact of avoidable harm on patients which suffered a delay of an hour or more in handover. What it found is that 8 in 10, so 80% of patients will suffer some level of avoidable harm as a result of a handover delay. And of course, then you've also got patients in communities which are not getting a response because the ambulance is delayed at the emergency department. And given the extreme level that some of our regions see in handover delays, the duration and frequency of those, you've also got an impact on our people too, quite a notable impact on our people in terms of their ability to acquire skills, or if they're new paramedics, to maintain their skills if they're existing paramedics. You've got all sorts of other issues which start to emerge in terms of moral injury and so on, where people can't do the job they joined for. So this is a significant problem for us globally as a sector. But you're right, here the academic work and the peer review work and the study indicates that 8 in 10 patients will come to some kind of harm as a result of a delay of an hour or more.
Jason, thank you for that. And we don't have a chat function on this webinar, but we'll make sure that via our social media channels, we'll make sure that we send out some of those links. And I know you've got that paper for us that we can share. Another international, or certainly from a US perspective, elephant in the room is that of training, education, qualification, certification. And we have touched on this. But Jason, I'm just going to stay with you to kick us off. I mean, talk about the graduate level of paramedicine in the UK, and I know it's going on in Australia. In fact, we're actively trying to recruit Australians to come and work in the US because of our recruiting issues. But sort of talk us through the sort of average, career pathway for an entry level, person that wants to get into paramedicine, say through a UK university system.
I mean, well, that could be a whole nother conversation, couldn't it, Rob, about recruiting?
Well, it's another webinar, but in
recruiting Australian paramedics, yeah, and having done that for a few years.
I was with you, mate, if you remember.
Yeah, indeed, into another place. So look, so paramedics here in the UK will do a 3-year degree with a university. They will complete that degree assuming they complete that degree successfully, then they can apply for registration with the HCPC and also for a permanent job with an ambulance service. Let's just say they get in and they're in a role. They will normally go through a period of mentorship. We call them newly qualified paramedics. There'll be a period, it varies slightly from trust to trust, from service to service, but there'll be a process by which they're essentially signed off as a paramedic. After that, then of course all sorts of opportunities start to emerge. They could become one of these specialist paramedics that I've touched on. They could go onto our hazardous area response unit. In some services, we operate cycle response or single staff, response vehicles. They could do that. They could work in our contact centers, in our control rooms as remote care paramedics, or go on to further education for masters to be an advanced practitioner, independent paramedic prescribing. So there are lots more, there are lots and lots of opportunities, Rob, for paramedics here in the UK. And of course, those that I'm describing are just in the ambulance sector. As registered clinicians, paramedics are frequently working, increasingly working in other bits of the healthcare system too. And so, paramedicine is seen and recognised by the NHS, by the health service, as a group of clinical professionals that can and do operate in other settings beyond the ambulance service.
Right. Is that reflective of the Canadian view, Kevin?
Yeah, absolutely. As I was mentioning earlier, paramedicine is being expanded to fill a lot of gaps in the healthcare system and really seeing the profession grow, and thinking about mobile integrated health in the spirit of AIM High, really expanding that beyond when we talk about true integration within the healthcare system, the role of paramedics and paramedic services to bring into other professions as interdisciplinary teams, multidisciplinary teams, to be able to respond to the specific needs of the patients that we're seeing. As a paramedic, I've always thought of us as a Swiss Army knife. Man, we're great at solving all kinds of problems. We got little tools in our bag to do anything, but you sometimes need that special tool. When we talk about truly managing a mental health crisis in our communities, we can train paramedics to be healthcare, mental health crisis managers, but truly sometimes we need that professional in there to help us. And so using the great attributes of a paramedic, in that live environment, combined with the expertise of a mental health professional in this example, really expands the ability of what we can do within the realm of our services, far beyond just the traditional ways that we think of paramedic services.
Matt, I'm going to invite you to be a contrarian here. Where are we and where do we need to go in the US?
I'm going to hold that thought. We got 5 minutes left. I want to have a lightning round question for the panelists here. Talked a lot about the paramedic profession, nationalized healthcare, part of the team, recognized as a profession. In a one sentence answer, what is the average salary of a paramedic in the Welsh NHS Trust and in Canada compared to the US? So Rob, we'll come back to the US, but for Canada, what's the typical salary for a paramedic? In Welsh, what's the typical paramedic for a salary for a paramedic?
So in Canada, and we're talking Canadian dollars, which of course we can look at whatever the currency exchange is, but in Canadian dollars, $100,000 as a paramedic, you can probably earn in a year, and more than that in some cases if you're a higher degrees paramedic.
Jason?
Okay, so paramedics in the UK are generally what we describe as band 6. So the entry point will be just about £38,000, up to just short of 45,000 is the top of the pay band. But I do need to make the point that they will be subject to up to 25% additional 25% of the salary in addition for working unsocial hours. So those figures I've quoted are the base salary, but then there's unsocial hours payments and others on top of that.
Rob, what is it here in the US?
It's a loaded question, Matt, and I come back to the 14,369 services across the nation. If you are one of my California ambulance organizations, you could be in the Bay Area as a paramedic starting in the sort of 70 to 120, 130 bracket. With overtime, that can be significantly more. If you're in other more rural areas of the US, that can be down to, I don't know, 40, 45, if that. So it depends where you go to what you earn. But of course, the great difference, and I discovered this a while ago, that when we were putting out an advert on the East Coast and said this is the salary, everyone on the West Coast went, my goodness, I wouldn't get out of bed for that. My reply is, of course, you can't afford, I couldn't afford to live on your salary in your location. So we are such a variation by geography. So it's a tough answer.
All right, and the last lightning round question. An emergency call comes in for an ankle injury in the 3 countries. What is the typical response for that?
Jason,
Okay. Well, look, there's all sorts of variables, Matt, that would go with it, but a straightforward 35-year-old male with an ankle injury would not get an immediate, or should not, perhaps let's put it like that, should not, in most cases, get an immediate lights, certainly not an immediate lights and sirens hot response from an ambulance. It would likely go to a clinician in a control room for assessment first.
Without even a response?
Potentially without a response, yeah.
Kevin?
Yeah, so pretty much the same, again, depending on what resources are available within the given system, whether it can go for a secondary triage to see if there's another route of transportation, if that's what's needed to manage. But one of the things that we do in Canada is we have a triage acuity scale that is used for the most part nationally, so that we can triage and evaluate types of calls. So in this case, it's probably a CTAS 4 or CTAS 5 if there's a low degree injury. And so using that terminology, we can talk about what a response plan would look like for a service.
Okay, and Rob, a last question coming in from the attendees. This might be our time for the last question. In all these countries, what percentage of your providers are volunteer?
Well, I will start with again, I have had the Virginia experience, okay, where Virginia, from my 10 years at Richmond, and I know there are folk from Richmond on, that a large percentage of EMS in Virginia come from volunteer rescue squads, and it's sort of the historic thing to look after your community. I don't want to put a percentage on it right now, but that number is diminishing sharply as volunteerism is decreasing.
Jason, Kevin?
Okay, Kevin, do you want to go next?
Sure. I don't have a number, but what I will say is it's very low. There's some volunteers across Canada in more the northern remote areas, but for the most part, it's the EMS paramedic services are staffed by somebody with a certification and paid to do that job.
Okay, and then similar position here. I mean, all of the NHS ambulance services are provided by salaried staff, so they're all full-time employees. However, what I should say is that there is quite a big volunteering element for community first responders and others who provide great service in our communities across the country, and indeed that's growing. So it's not diminishing, perhaps as you're experiencing, Rob, but we're certainly growing volunteering here.
Yeah.
But the core ambulance service is all salaried.
And that's another webinar in itself. I think CFRs in the US, Israel, Hatzalah, community first responders, another discussion for another day, perhaps. Matt, do you want to bring this to a close?
Yeah, just want to thank our panelists, and I think we should all send Adam
Yep.
get well wishes. But certainly for Jason, Rob, Kevin, amazing webinar. Thank you for sharing your expertise, your insights. Hopefully there are some things that we might want to change here in the US and vice versa with how EMS is delivered across the country. For the attendees, just remember, you'll be getting an email tomorrow with a link on how to download and access the recording and the materials. We really appreciate everybody joining. Rob, do you want to close us out?
Yeah, thank you very much. And thank you all for those that, as I say, for those that are here live, thank you very much. For those that are watching this on demand, thank you again for viewing this. As you've heard, we are separated by differences and similarities. We have some issues that are truly global, such as ambulance patient offload time, recruiting retention a challenge, funding models different. I've had the pleasure and honor to travel around the world talking to paramedics. I can also guarantee that after about 30 seconds, we have the same gripes, moans, whines, and complaints. That's a given because we're all of the same mindset. That was our webinar, putting the I into Aim High, looking at those essential differences and also similarities and challenges from around certainly our three nations here. Remember, please stay with Aim High. We've got a lot of stuff coming up, and if you want to join us, reach out to Matt and I. Matt, back to you.
Thank you all. Have a great rest of the day. Bye-bye.
Thanks, everybody.